breast surgical management for the primary care provider, a 2020 vision. Again, I am Dr. Vivian Jollibee. I have no disclosures. Some objectives. So I'm going to describe historical context of breast surgical management and discuss modern day breast surgical management strategies. I'm going to review the major prospective randomized clinical trials that formed our surgical decision making, and then discuss some disparities in breast cancer care among Black women. And here's a question for you. Please answer true or false for the following statement. In 2020, the National Comprehensive Cancer Network, NCCN, guidelines support minimal axillary surgery in the form of an axillary sentinel lymph node dissection for women with early stage breast cancer. I'd like to start out with some breast cancer epidemiology, which you have heard earlier this week. The estimated new cancer cases in the United States in 2020 has breast cancer as the #1 cause for cancers in women. If you look at the estimated cancer deaths in the United States for 2020, breast cancer is the second leading cause of death in women. When we look at trends in breast cancer incidence by race, because this week we really are diving into racial disparities as it relates to breast cancer. We see here that white and Black women have sort of similar incidence, with Black women slightly less likely to be diagnosed with the breast cancer. However, if we look at trends in breast cancer death by race and ethnicity, we see a divide. We see that although Black women are less likely to be diagnosed with breast cancer, they're actually 44% more likely to be diagnosed, 44% more likely to die from a breast cancer diagnosis. That in itself is a breast disparity. Now, breast cancer mortality certainly has declined over the past 20 years in the United States. And this improvement in outcome can be explained by improvement in earlier detection with screening mammography and also systemic therapies. But unfortunately, these novel approaches really have not made a great difference for Black women, as there still is a disparity. So when we look at the incidence, breast cancer incidence is slightly lower among Black women than white women. However, mortality is 40% higher. This cause is certainly multifactorial. So we can spend all weekend, we certainly are spending all week talking about some of the factors that lead to or cause breast disparities. It can be tumor biology. Black women are more likely to be diagnosed with a triple negative breast cancer, which portends a worse prognosis. Modifiable risk factors certainly can contribute. Social determinants of health, environment, social economic status, which sort of leads to access to care, as well as screening. So there are many causes as to why breast disparities exist. And really, it is time for us to not only sort of ask the questions, continue to ask the questions, but also come up with ways that we can address and eliminate breast disparities. Dr. Martin Luther King Jr. said it best: of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So in 2020, how do we address health injustices and breast disparities? That's the question that we should all ask ourselves. One such way is to understand best treatment strategies for all patients, Black or white. Once this is done, it's important for physicians and providers to equip patients with the tools that are necessary to improve outcomes. So in 2020, where are we? What is our vision? Where are we going? And also, where have we been? I'm going to spend the next part of this discussion talking about the evolution of breast surgical management to understand where we have come. And then we're going to move it to present day, where we are, and relate it to where we really need to go. So the 2020 vision. Breast cancer treatment has evolved over centuries, with really no treatment for what was a fatal disease, to aggressively high morbid surgery, to present day in 2020, where we can offer women minimal yet thoughtful surgery with improved outcomes. In 1894, William Halsted introduced the radical mastectomy as a form of treatment for breast cancer. A radical mastectomy consists of the removal of breast, as well as the underlying chest muscle, including the pectoralis muscles, and regional lymph nodes levels 1, 2, and 3. Just a little bit of history. William Halsted was actually born in 1852 and was born and raised in New York City. He actually went to Columbia and was known as the pioneer of general surgery, and was credited for the aseptic surgical technique during surgical procedures, and also for introducing the surgical technique of the Halsted radical mastectomy, which we just talked about. So Halsted believed that most important pathway for breast cancer spread was through lymphatic ducts, and that the chances to cure breast cancer were increased by removing all lymph nodes. This gave rise to the extended radical mastectomy, which included median sternotomy and internal mammary node dissection, in addition to the removal of the breast skin and axillary lymph nodes, as well as the pectoralis muscles. While surgeons enthusiastically embraced this radical approach because it certainly was at least something, it was also an operation women became most to fear due to its high morbidity. And there's a quote from Dr. Halsted that says, "Most of us have heard our teachers in surgery admit that they have never cured cancer of the breast. We rarely meet a physician or surgeon who can testify to a single instance of cure for breast cancer." And so the Halsted mastectomy really was an opportunity to offer some therapy for women with breast cancer. And over the years, we have really evolved in our treatment of breast cancer. During this evening's talk, I will take you through treatment advances that we have made along the way and related to current day disparities in breast cancer treatment and care. From the Halsted radical mastectomy to the modified radical mastectomy, which actually preserves the major, pectoralis major and minor muscles, to breast conservation surgery, which you can see here is limited surgery, removing the breast cancer and offering patients radiation at the same time. That's the definition of breast conserving surgery. So lumpectomy with radiation, where we can save or conserve the breast. We're going to first start with addressing some landmark breast clinical trials with the NSABP B4, then B6. We'll also discuss the NSABP B32 and the landmark trial, the ACOZOG Z11 trial. Then in 1977, Bernard Fisher led the NSABP 04 landmark trial that sought to compare the surgical treatment of node-positive patients to node-negative patients. 1,765 women were enrolled between July 1971 and September of 1974. These women had stage 1 and 2 breast cancers. And as you can see, for the node-negative breast cancers, patients were divided into radical mastectomy, total mastectomy with radiation, as well as total mastectomy. And for the node-positive women, radical mastectomy and total mastectomy with radiation. What they found was no difference in disease-free survival or overall survival, as illustrated here. Now with 25 years of follow-up data, again, there's no difference in the 3 groups of women with negative nodes or 2 groups with positive nodes in terms of disease-free survival, relapse-free survival, distance disease-free survival, and overall survival. In 1973, Bernard Fisher began to design a second randomized trial, the NSABP B6 trial. And this was really designed to evaluate the efficacy of breast conserving surgery in women with early stage 1 and 2 breast cancers that were less than 4 centimeters in diameter. Patients with both clinically negative and positive nodes were included. And as you can see here, the groups were stratified again based on nodal status and clinical tumor size. And then patients underwent a modified radical mastectomy, which is a total mastectomy with the axillary lymph node dissection, a lumpectomy with an axillary lymph node dissection, and a lumpectomy with an axillary lymph node dissection and radiation. And the results also showed no difference in 5-year disease-free survival, distance disease-free survival, or overall survival. So the B6 clinical trial showed us that lumpectomy with radiation continues to be an appropriate therapy for women with breast cancer, provided the margins of resection are free of tumor and acceptable cosmetic results can be obtained. So this is really important because current day, a number of women are great candidates for breast conserving surgery. And as we talk about breast conserving surgery, I wanted to show you some pictures. Again, if you look here, we are really able to minimize scar and to conserve a woman's breast at the same time. Oftentimes we'll make an incision around the nipple or hide the incision at the inframammary fold. Also an option is to do an incision sort of in the axilla. And you can see here, this is a lumpectomy after we have removed it. Again, a lumpectomy should be paired with radiation for breast conserving surgery. And if you can take a look here, we have used different types of localizers across the country, whether it is a wire or whether it is a seed of some sort, but we're able to really localize the cancer and really be thoughtful about what we remove and maintaining a great cosmetic outcome for our patients. And then, of course, you have a mastectomy, and a mastectomy certainly is also an option for women who desire it, or who, for example, are not candidates to receive radiation, or whose tumors are too large to offer lumpectomy. Because the cosmetic outcomes would not be appropriate. And a mastectomy can be done as a total mastectomy, a skin-sparing mastectomy, as well as a nipple-sparing mastectomy. Here's an example or examples of skin-sparing mastectomies with different incisions. Typically, we will make an incision around the nipple areolar complex and invite our plastics colleagues to perform plastic reconstruction at the same time. You also have a nipple-sparing mastectomy for certain carefully selected patients, where we are able to actually preserve the nipple, preserve skin, remove, of course, the breast underneath, and again, we're conserving the pectoralis muscle. And this again is done at the same time with plastic surgery for reconstruction. So we talked about breast surgeries. And so as breast surgery management has evolved, so too did the axillary lymph node dissection for all breast cancers. And axillary lymph node dissection evolved to what we call a sentinel lymph node biopsy. And a sentinel lymph node biopsy should be offered to patients with minimal disease burden. An axillary lymph node dissection certainly reliably identifies regional metastases, and it historically has done so. It also provides regional control and decreases the risk of axillary recurrence. However, it is met with complications that we should not ignore. So women who have an axillary lymph node dissection have a risk of developing lymphedema, which is swelling in the arm from 20 to 30%. As well as risk of nerve injury, shoulder dysmotility, and chronic pain. Sentinel lymph node biopsy for the breast was described in the early 1990s and really was used initially for melanoma surgery. First article of blue dye mapping in breast was published in 1994 by Dr. Giuliano. And as you can see here, we inject blue dye. We also use radioactive substance And that takes us to the node that if cancer cells were to go, they would go to certain nodes, and we remove those gateway nodes, as we call it. Validation of the sentinel lymph node biopsy for breast cancer came from the NSABP B32 randomized controlled trial that was conducted from 1999 to 2004, accruing 5,600 women with invasive cancer. These women were clinically negative in their axilla and were randomized to a sentinel lymph node and routine axillary lymph node dissection versus a sentinel lymph node biopsy with axillary lymph node dissection only if the sentinel lymph node was positive. And outcomes were no difference in overall survival, disease-free survival, or regional control. And as we look at the NCCN guidelines, which are the National Comprehensive Cancer Network guidelines that help frame and guide us as we make decisions and offer treatment plans for patients, it's important to note that this is where the NSABP B32 came into play. Again, for clinically negative breast cancer diagnosed, sentinel lymph node biopsy is an appropriate step. And for sentinel lymph nodes that are negative, no further axillary surgery is necessary. So sentinel node biopsy has become the standard of care, again, in clinically node-negative patients. And the question then becomes, for sentinel lymph node biopsy that are negative, of course, no further axillary surgery. But what about sentinel lymph node biopsy that's positive? Well, let's discuss the ACOSOG-Z11 trial. So the ACOSOG-Z11 trial really challenged this and looked at clinically T1, T2 invasive breast cancers with no palpable lymphadenopathy, no evidence of metastatic spread, and allowed up to 1 to 2 sentinel lymph nodes that were positive. Patients were excluded if they received neoadjuvant chemotherapy, if they had matted nodes, or if they were found to have greater than 3 positive sentinel lymph nodes. The trial accrued 891 patients who were positive for, who were found to have a sentinel lymph node that was positive, and they and 388 underwent axillary lymph node dissection, 425, no further axillary surgery. And these were for patients who underwent breast conserving surgery, had planned whole breast radiotherapy, as well as systemic therapy. The primary endpoint was overall survival, and the secondary endpoint was disease-free survival. The axillary group did have 27% additional lymph node metastasis, with a median follow-up of 6.3 years. So the ACOSOG-Z11 trial shows us that for women with early stage breast cancer who undergo breast conservation surgery, sentinel lymph node biopsy is a viable option as it relates to comparison with axillary lymph node dissection. Disease-free survival is the same. And it has become our standard of care. Thus, omission of axillary lymph node dissection is safe with no difference in survival in patients with early breast cancer and limited sentinel lymph node involvement who undergo breast conservation followed by whole breast irradiation and adjuvant systemic therapy. And if we go back to the NCCN guidelines, you will see here that this is what is outlined in the NCCN guidelines, that patients with T1, T2 tumors are allowed 1 to 2 positive sentinel lymph nodes, as long as they undergo breast conserving surgery, undergo whole breast radiation, and no preoperative or neoadjuvant chemotherapy. No further surgery is necessary. So 2020 vision. So we've talked about our metamorphosis of breast surgical management from the radical mastectomy to breast conserving surgery, and from axillary lymph node dissection for all women with breast cancer to sentinel lymph node biopsy for patients with early stage breast cancer. The question is, do surgical breast disparities exist in 2020? So to answer this question, disparities in breast conserving surgery, there are a number of retrospective research that has looked at this very question of breast conserving surgery. Researchers at MD Anderson in Texas conducted a retrospective study using the National Cancer Database to examine over 727,000 surgical women with early stage T1 and T2 breast cancers between 1998 and 2011. They found that breast conserving surgery rates were lower in patients without insurance compared with those who had private insurance, and lower in those with the lowest median income. Academic cancer programs also had a greater breast conserving therapy or breast conserving surgery rate than community cancer programs. So this really speaks to the fact that although breast conserving surgery has become the standard of care and has increased for most over the last few decades, non-clinical factors such as socioeconomic status, insurance, zip code continue to be barriers for some. I truly believe that your zip code should not determine the quality of care or the standard of care that is being offered. And unfortunately, in our country, it still does, and that's unfortunate. And we have to figure out ways to continue to address this disparity. So what about disparities in axillary management? Again, a number of retrospective studies that have looked at this very question. A study by Nayar et al. Looked at the National Cancer Database for women diagnosed with breast cancer between January 2013 and December 2015, who had clinically early stage T1, T2, N0 breast cancer and underwent sentinel lymph node plus or minus axillary lymph node dissection or axillary lymph node dissection alone. After adjusting for demographics and cancer characteristics, Blacks and Hispanic women were more likely to receive an axillary lymph node dissection, and patients without health insurance and those treated in community centers compared to academic centers were also more likely to receive an axillary lymph node dissection. Again, we see in underutilization of sentinel lymph node in early breast cancer for Black and brown women. Black et al. Also conducted a retrospective study using the SEER database from 2002 and 2007, identifying over 32,000 women with pathologically node-negative breast cancers. They found that throughout this period, Black patients had an absolute 20% lower likelihood of a sentinel lymph node biopsy compared with white women. They also found that Black patients undergoing axillary lymph node dissection had a higher rate of lymphedema compared to white women. Over the years, we continue to improve. The disparity cannot be ignored. We really have to continue to look at this with a magnifying glass. It doesn't come without issues. An axillary lymph node dissection, as I discussed, has an increased risk of lymphedema. And so the morbidity that's associated with that is increased for women who receive an axillary lymph node dissection. So we should really be thoughtful about patients and whether they need an axillary lymph node dissection. Now, there are patients who certainly need an axillary lymph node dissection, but for those who we can safely omit a axillary lymph node dissection, we certainly should strive to do so. And what about locally advanced breast cancer? Well, we talked about early stage breast cancer, and locally advanced breast cancer accounts for about 10 to 15% of newly diagnosed breast cancers. If you look at and inflammatory breast cancer, which is a subset of locally advanced breast cancer, accounts for 1 to 5% of newly diagnosed breast cancers. And these cancers have a higher incidence of local and distant relapse and poor survival. If we look at the TNM staging, we can see that locally advanced breast cancer are those T3, T4 tumor sizes. And again, inflammatory breast cancer fits within that. The nodes are often matted or more extensive than the early stage breast cancer. And then when you look at defining inflammatory breast cancer, minimal criteria required for diagnosis of inflammatory breast cancer, rapid onset of breast erythema, edema, and pleural range. So when we look at patients, often they will come into our practice, right, with a new rash. And I would say for every patient, we should treat them seriously. Typically, the first line within the community is to give patients antibiotics, but I would sort of stress that in addition to antibiotics, work up with with breast imaging and mammogram, ultrasound, and referral to a breast provider is imperative, because the earlier we diagnose these inflammatory breast cancers, the better survival. And so it should be worked up and vetted thoroughly. So inflammatory breast cancer, again, rapid onset, warm breast, a duration history of no more than 6 months, and erythema occupying at least 1/3 of the breast. Again, you want a pathologic confirmation of invasive cancer. And oftentimes we will perform a skin punch biopsy. The treatment for inflammatory breast cancer is trimodal, and I can't stress enough the importance of a trimodal approach for inflammatory breast cancer. If you look at a study that was conducted by Daewoo et al., you would see that when we look at survival for inflammatory breast cancer, survival is improved with the use of trimodal therapy, and that's neoadjuvant chemotherapy, modified radical mastectomy, and then post-mastectomy radiation. These patients really should not receive surgical management up front. For the most part, neoadjuvant approach as the first line of therapy is helpful. It helps control the disease and really treats the body systemically, followed by surgery. And of course, there are disparities. There are disparities in inflammatory breast cancer. As you can imagine, access, early diagnosis certainly play a role. And what about disparities in breast surgery during the COVID-19 era? So COVID-19 has exposed racial and ethnic disparities in our healthcare system. And during the height of the pandemic, recommendations from the American Cancer Society, the Society of Surgical Oncology, and the American Society of Breast Surgeons recommended surgical delay. Now, this was certainly necessary as we were in the epicenter in New York. We had to sort of be thoughtful about the resources that we used. However, it's feared that surgical delay for breast cancer patients, which was maybe time from screening to biopsy, or biopsy to surgical intervention, as well as surgical determinants of health, such as financial reserve, housing, stress, transportation, loss of insurance, maybe due to loss of job, and access to care may further widen the breast disparities gap. Interventions are needed in all of our communities to address these disparities head on. Some things that we can sort of think about, improve and encourage screening mammography. And we have throughout this week presenters who are going to talk about screening mammography and the appropriate age to refer patients for screening mammography, but also following up and making sure that that all patients have their screening mammography and are not delaying it because of COVID. Improving access to screening mammography, perhaps extending hours. We have been able to extend hours for mammography screening at NYP Brooklyn Methodist. And so we encourage all centers to sort of think about strategies that can help your communities to provide better access to mammography for all women. Perhaps navigation systems, if you have them in place, extend those to the community with social worker help for insurance issues. And of course, all of this, but practicing standard of care. So understanding the standard of care for early stage breast cancer as well as locally advanced breast cancer. And then as we look again, systemic structures can, paired with sort of social determinants, can lead to decreased access, decreased mammography screening, decreased access to breast cancer treatment, and worse outcomes. And so encourage your patients to go and get screened. Encourage your sisters, your friends, your colleagues to get screened and to follow up. And find, navigation systems in your area that can help assist and improve access for all patients. And again, standard of care is so important as we strive to eliminate breast disparities. We have a number of wonderful presentations for the remainder of this week. We've had some great presentations at the beginning of this week. And so I'm thrilled and really hope that you've been able to gain some knowledge on breast surgical management. And here's our question again, true or false? In 2020, the National Comprehensive Cancer Network guidelines support minimal axillary surgery in the form of an axillary sentinel lymph node dissection for women with early stage breast cancer. And the answer is true. Take care and have a great evening.